that seems to be a bit more breathing related, and the REM sleep bruxism, which seems to have more of a psychiatric or psychological overtone. So why should bruxing and air maintenance have something in common? I was trained a couple of years ago in a program I did in Sydney, and there was this wonderful professor, an ear, nose and throat. And he just stood up and he stuck that up, and I hadn't seen that in 23 years of dentistry. No one had ever told me that. No one. Oxygen is our most vital nutrient. 3 weeks without food, 3 days without water, 3 minutes without oxygen. You starve the body of oxygen and you're going to pay a price, be it acutely or chronically. The problem with oxygen, we take it for granted. Costs us nothing, can't smell it, can't see it. But I would say tonight that it's a lack of this which is causing most of our problems that we see in the chair. So nose breathing is normal, mouth breathing is abnormal. God gave us a nose to breathe. And really the key differences here is nose breathing. We condition the air, but we also release a wonderful hormone called nitric oxide. And nitric oxide plays a few roles in the body, but its key thing is it's a vasodilator within the base of the lungs, so it helps the gaseous exchange. It also helps the coupling of oxygen and haemoglobin. So people who are deficient in nitric oxide have some problems. So that's one of the problems that we have with mouth breathing. We don't get any nitric oxide. I think the other thing to appreciate here is that the nasal airway is not affected by tissue tone. It's a bony structure. It's tented open. But when nasal breathing fails to meet oxygen demand, then we have no choice to go to the mouth. And that's the next red flag. Turning from nose breathing to mouth breathing, and what are the triggers for it? So, conditions that increase airway resistance. Now that can be upper airway, it can be lower airway, but I'd argue 90% of it would be between the bridge of the nose and the base of your tongue. Things that put your body under load. So this is the hormonal imbalance, it's the stress, the physical and the psychosocial. It's the chronic pain states, the neuropathic pain patients. And it's things that affect oxygen carrying capacity of blood, anemia. So who in this room would think that anemia would predispose to tooth decay in a female? Not one, I reckon, but I would. And you're not taught that. Anemia is a real big one in women, right? Because it's a big cause of bruxism. So again, don't get swept off on the breathing thing. It's a balance. Airway is one part, B is things that put the body under load, and C is your blood. Very, very important. Tissue tone, lung volume and respiratory drive act to maintain our airway whilst we're awake. But unfortunately, we're not afforded that luxury in deep sleep, what we call slow wave sleep, and REM sleep. And this is when we develop, when we're mouth breathing of course, what is called is sleep disordered breathing and related hypoventilatory states. And that then triggers the bruxism, and now we start to see the ingress and the correlation with all those medical conditions that I put up on an earlier slide that I just found to happen in all these people with bruxed, but I didn't understand why. And so that medical questionnaire you have in front of you, I didn't do it on my own. That was done by a group of 60 people, and 20 were dentists, the rest were medicos. And out of the medicos, 70% were specialists. And it was a brainstorming day for 3 days to develop a medical history that we could use to screen patients with. Best 3 days I've ever had in dentistry. And you're free to use that, all right? So we need to understand that sleep disordered breathing, if we just look at that top part A for the moment, I believe it's an ENT problem as opposed to the domain of a sleep physician. And you will come across this dilemma as to whose pasture these patients should be put in. You know, largely, I don't care what anyone says, it comes down to power, politics and money. You speak to a respiratory physician, oh, they've all got to come to me. You speak to an ear, nose and throat doctor, oh, they've all got to come to me. Well, the reality with it is they've got to be managed by all of us. Not one person can treat this condition. It is multifactorial, and you need a team approach. It cannot be managed by a sleep physician just whacking them on a CPAP. It cannot be managed by an ear, nose and throat doctor cleaning out their nose. And it can't be managed by a shrink trying to get them through a few, with anxiety and depression. It's multifaceted management. Unfortunately, in the medical sector, we don't have this degree of collaboration. In the East, the boundaries are breaking down real quick because they can. But here, it's a little bit insular. So 70% of the population has some level of sleep-disordered breathing, and sleep-disordered breathing is spectrum. It is not obstructive sleep apnea. It goes from snoring right the way through. Okay? We understand that there's 80 different sleep disorders, but 80% of which is largely to do with OSA, and OSA carries the greatest morbidity and mortality. 90% of all apnea is obstructive, and it's usually along the base of the soft palate. And that's another good saying. This professor gave us this one. That was a beauty. You can snore and not have OSA, and you can have OSA and not snore, but you need to appreciate that snoring's the thunder and the apnea is the lightning. And silly me, I put my head up and said, sorry, Professor Albert, don't quite understand that. And he said, lightning will kill you. I thought, I understand that now.
Can I add something?
Yes.
According to the sort of best figures we have, of those people with sleep apnea, some estimates are that 80% of people are undiagnosed.
Yeah, actually, I might have something here. That's a good point. I may not have put that in. That's a good point. Absolutely. And most of it's picked up just by chance when they're having sleep studies for other things. We understand that males are a little bit more susceptible than females. And they think this might be to do with hormonal differences and tissue tone and a few other bits and pieces. Blokes put on weight around the neck. Women put on weight. Where do women put on weight, Dr. Nolder? Be careful, mate. Around their ass, right? So blokes around the neck, women's around the butts. And they think this is a contributing factor. We understand that we have obstructive sleep apnea, which is the snoring and the gasping for air in my sleep, either reported by the bed partner or being self-aware of it. And then we have the obstructive sleep apnea syndrome, which is the same, but you just add daytime somnolence or daytime tiredness. So obviously the syndrome is obviously going to be grossly underreported compared to the OSA as such. And again, I'll come to that in a minute as well. The other interesting thing, I had a really good program in Melbourne by, if you ever get the chance, well actually some of you guys might have already seen him, and his name is Professor David McIntosh, and he came and lectured here in March, and unfortunately I wasn't here, but I was really intent on going and seeing him, so I went to Melbourne and caught up with him over there. And the thing I like about Professor McIntosh is he's young, he's got a lot of vigour in what he does, and he's really challenging concepts of teaching. And he's really blowing this apple wide open. And I really take my hat off to him. So he's travelling up and down the eastern states, talking to doctors. He's been poo-pooed by his specialty, saying that, you should be doing this and blah-de-blah-de-blah. But you know what? He is one person you need to listen to if you get the chance. Obviously, it's got a large lean on ENT, but all the same, it's very, very useful. He's a paediatric otorhinolaryngologist, and therefore he says snoring in kids is abnormal. So if kids snore, that's abnormal. 1 in 5 can have OSA, but only 1 in 7 ever get to see an ENT. Now that scares me. And again, I'll explain why in a minute. We need to appreciate that upper airway issues, nasopharyngeal obstruction / restriction in kids, or sleep-disordered breathing in kids, it can manifest into fully blown OSA in adults if it is not aggressively managed in formative years. And also that paediatric OSA is a very different animal to adult OSA in the way it is assessed and the way it is treated. And the implication for a non-managed paediatric OSA patient is different to the implications for an adult OSA. I won't bore you too much with this. This stuff you can get off Google, right, Dr. Nolder? Right? But the main thing to appreciate here is upper airway resistance syndrome. We're under the radar, there's no apneas, there's no hypopneas, nothing's going to kill you. We get what are called respiratory effort-related arousals. Now, these respiratory effort-related arousals are more common in the females than the males. These things will cause a lot of bruxism, and you might have 200 of these in a sleep hour. But you might have 1 or 2 hypopneas in an hour. And the other problem with REA is they're only picked up with laboratory-based sleep assessments. The home base are not fine-tuned enough to pick it up. So we need an attended sleep study to pick it up. And so here's a good one, where I had dealings with a sleep physician 12 months ago, and basically this patient had a home-based sleep study because it's quick, it's cheap, it's easy. And home-based sleep studies are, for all intent purposes, used for the patient where we are fairly confident their main problem of sleep dysfunction or sleep disorder is obstructive sleep apnea. If there are other comorbidities and it doesn't quite fit, then they're in a hospital and they have a laboratory-based sleep assessment. The problem is cost and beds. It doesn't matter. But it doesn't mean everyone should just have a home-based sleep assessment and then they're told that they don't have sleep disordered breathing because they've got an AHI less than 5 and there's no bruxism. So therefore, sleep bruxism and OSA, this particular case I was thinking about, go back, had an AHI of 15, but there was no signs of sleep bruxism. And this sleep physician questioned that really there is no connection here between sleep disordered breathing and sleep bruxism because there's no bruxism going on. Well, the problem with it is I grind like a banshee and I wouldn't know it. I can clench and make no noise, but we understand that the clenches are the silent assassins. They will generate a lot more force than the bruxer. Because for you to clench and keep your jaws stationary, you're contracting with a lot more force. So clenches are the silent assassins, what I call the smilers of denial. I don't clench my teeth. I don't grind my teeth. But don't be sold by them. So just because we see sleep studies and there might be some reference that no, there isn't connection with bruxism here, look at the sleep study. Was it home-based? Was it lab attended? Because I could have an AHI of less than 5, but I could have an RDI of 40. And I'll talk about that in a minute. And the RDI, the only difference is we're adding the rearers. So it's the respiratory effort-related arousals that are really causing the bruxism. It's the apneas and the hypopneas that are probably making us sick and killing us. And again, a lot of that is self-explanatory. I'm not going to go through that, other than to say the fortunate thing is OSAS is a notifiable condition. So when I get a patient coming in and they tick a few red flags in my medical history and they're smashing their teeth to bits, and I say, you know what, really we need to get you off to your doctor, we need to get this appraised, we should get a sleep study. I mean, the number of patients that said to me, say, mate, I'm not going anywhere near a sleep study. And I'll say, well, why? And they say, mate, if I get diagnosed with this, then I've then got to have this treatment to keep my licence. We have a problem there. And that's a real problem. Now, what is changing is some of the trucking companies, for drivers older than 50, for them to keep their job, they now have to have a sleep study once a year. It's part of their medical. Don't have a sleep study, don't work for me. Same in mining companies. And that's a very positive move. Very positive move.
Tim, can I add to that?
Yes.
I've done some work in trucking companies in the UK.
Yep.
Where we showed that individuals at high risk of obstructive sleep apnea had a 3 to 7-fold increased risk of road traffic accidents.
Yeah.
In truck driving.
Yeah.
So people, the average number of accidents is 0, but even so, even though it's a low rate, fortunately, event.
Yeah.
So 3 to 7-fold
It's very high.
It's tenfold increase in accidents.
Very, very high.
People with OSA
And it's scary to think that we have patients or people out there driving these big trucks who are saying there's no way I'm going to have a sleep study. But fortunately the tide is changing there. So a little point then on RDI and AHI, and don't get bogged down, all they are is indices. I'm not a big believer in this. I don't think we can latch everything on RDI and AHI, but I personally find RDI therefore a lot more useful. But I'm only going to get it from a laboratory-based sleep assessment. But that will then help correlate more what I'm seeing at a dental level with their bruxism than an AHI line. So I could have an AHI, which is just recording the apneas and the hypopneas and missing out on the rears, and they're smashing their teeth to bits, but they don't have sleep disordered breathing. So then the Swami sleep physician says there's obviously no correlation because this patient has no sleep disordered breathing, but you're saying that they're bruxing. There can't be a correlation. This is the problem. Just because they're specialists, it doesn't mean they're up with it. The tide again is changing. I find sleep physicians are starting to report RDIs, and particularly if you have a laboratory-based sleep study, it's axiomatic. But I really think that's one positive move, all right? But you'll only get it from the lab, not the hospital, not from the home-based studies. And we understand that the rears are more implicated with the sleep bruxism, only because it's happening 200 times an hour, with apnea and hypopneas might only be happening 30 times an hour. So every 30 times, that's 30 arousals versus 200 rearers, well, that's 200 arousals. And on that basis, I think AHI is a poor